Welcome to the Ticktective podcast and video series, a program of the Bay Area Lyme Foundation, where our mission is to make Lyme disease easy to diagnose and simple to cure. I'm your host, Leah Gertner, Director of Education and Outreach. Lyme disease is the most common vector-borne disease in the USA and is a global issue. This show includes interviews with the researchers we fund, as well as other interesting people in the Lyme scientific community. We are a nonprofit foundation based in Silicon Valley. Thanks to a generous grant that covers all of our overhead, 100% of all donations go directly to support research and prevention programs. You can find out more or donate at bayarealyme.org. Welcome, Dr. Dale Bredesen, to the Ticktective podcast and video series.
Thanks so much, Leah.
Dr. Dale Bredesen earned his medical degree from Duke University Medical Center and served as chief resident in neurology at UCSF before joining Nobel laureate Stanley Prusiner's lab at UCSF as an NIH Postdoctoral Fellow. Dr. Bredesen has held faculty positions at UCSF, UCLA, and UC San Diego. Dr. Bredesen also directed the program on aging at the Burnham Institute before joining the Buck Institute in 1998 as the founding president and CEO. Dr. Bredesen has published many scientific journal articles and holds over 30 patents. He is the author of the New York Times best-selling book, The End of Alzheimer's, as well as the First Survivors of Alzheimer's. Is there anything you want to add to that, Dr. Bredesen?
No. Oh, good.
Your book talks about, well, I have your book right here. I have a couple of your books right here. They're really easy to read and full of really useful information. I think it's interesting how you got started on the Alzheimer's research track. Do you want to share with our listeners a little bit about that?
Sure, yeah. I mean, I was interested in the brain from when I was a freshman in college because of a book called Machinery of the Brain by Dean Wooldridge of Thomson-Ramo Wooldridge fame. And he compared it to the workings of a computer. And I thought that was really intriguing. And so I was interested in, how do you get memories? How do they form? How do they remain? Things like that. And then from there, got interested in the brain disease. Why is it that it's so incredibly common? If you look at, for example, the pandemic, we now have over 1 million Americans who have died from COVID-19. But about 45 million of us, of the currently living Americans, will develop Alzheimer's disease if we don't find a way for prevention and reversal. So it really dwarfs the COVID-19 pandemic. So incredibly common. And why is that? And what are the drivers? It's been the area, as you know, of greatest biomedical therapeutic failure. People say, everyone knows a cancer survivor, no one knows an Alzheimer's survivor. And I think that's a good point. There hasn't been anything, whether you're talking about Alzheimer's or frontotemporal dementia or Lewy body disease or ALS or any of these things, there really hasn't been anything. And so we wanted to understand the fundamental nature of the neurodegenerative process. And we spent 30 years in the lab looking at what are the things that actually led to this decline. Finally, in 2014, we had the first examples of reversal of cognitive decline. And then just recently, we posted the first example where we had a clinical trial where instead of just trying to slow the decline, we actually see people getting better and staying better. So very, very enthusiastic about that.
And you talk in the book about how your wife was the one who said, if you just take a step back and look at the whole body system and the things that humans need to be healthy that they've evolved with, like sleep and healthy diet and clean air, and maybe that's the key. Instead of, you said, we don't have one drug that works. There never has been one drug that works. So there's no silver bullet. But you're saying we're coming up with silver buckshot because we've got so many different ways of coming at this disease using, I guess, what we might call functional medicine, integrative health.
Yeah, absolutely. And of course, I should have listened to my wife 25 years ago when we were early on in the research. She said to me, whatever you guys come up with in your research, it's going to have something to do with fundamental things like nutrition and sleep and things like that. And of course, at the time, being a reductionist, I said to her, no, we're going to find one molecule, one fold of one molecule. We're going to get a drug, we're going to hit that fold, and everything's going to be great. Well, what happened was we could actually follow this from the test tube. It's really interesting. You look at the things that are actually driving the decline, and you can see that there's a switch in the middle of all this that responds to insults. So it's very much like what happened with our country in COVID-19. You have an insult, which in that case was a virus, of course. And so we were told shelter in place, social distancing, pull back, don't go to work as often. And what happened? We went into a recession. Well, your brain is doing the same thing with cognitive decline. It looks at, are things good, in which case you're going to be able to make and keep connections, or are things bad, in which case you've got insulin resistance, for example, or poor sleeping, or ongoing inflammation from things like tick-borne illnesses, mycotoxicity, metabolic problems, leaky gut. It turns out there are dozens and dozens of these things that can contribute. But at the heart of the problem is that the supply for your neural network that you're using to make the memories is exceeded by the demand. And therefore it is literally pulling back and protecting itself. And what we see as the problem in Alzheimer's is really a response to these insults. So just as my wife suggested all those years ago, we have to identify all the things. And if you think about it for a minute, it makes no sense to try to treat a complex chronic illness without understanding what is driving the illness. Why are you actually having this? And yet all of the treatments for Alzheimer's have been predetermined. Okay, we're going to give you this medicine or that medicine, instead of saying, okay, we're going to first determine why did you get this problem? And then we're going to target those things. And there are often several of them that all need to be targeted and optimized to get the best outcome. So it's really been a revelation to see that when you identify these things and then you target them, you get much better outcomes.
And you talk in your book about a house that has 36 holes in the roof. You want to share what that metaphor means in terms of your protocol?
Absolutely. And so we looked at how many of these different mechanisms are contributing, things like leaky gut and things like Babesia and Bartonella and Borrelia and all these things. And we initially identified 36 different contributors. And so what we tell people is, imagine you have a roof and it's got 36 holes in it. A drug is a great patch for one hole. But what about all the other things? If you're really going to have a change, you're really going to have to now address all these things. So you've got to look, and then you've got to address those things to get the best outcomes.
And what do you find of those 36 holes? And I know you talk about this in your book, how people ask you which of the 36 holes are the most important to fill. And ideally, everyone should fill all of them. So they should work on their diet and their sleep and take this supplement and make sure they don't have underlying infections like Lyme disease and tick-borne disease and viruses. But if you could name the top in terms of effectivity, and then maybe also thinking about the ones that are most accessible.
So there are 4 groups. I think that's the way to start. So there are 4 groups of things in this balance for your plasticity. And the first one is inflammation. And so, of course, this is where if you've got tick-borne illnesses, if you've got chronic infections, P. gingivalis from poor dentition, for example, if you've got a leaky gut, so many of these things that give us ongoing inflammation. You can literally trace the molecules from inflammation to the amyloid of Alzheimer's disease, which, by the way, is part of your innate immune system. So you can trace this, the molecular pathways. So inflammation is number 1. Number 2 is toxicity. If you've got ongoing mycotoxins or inflammatory, for example, toxins from air pollution as being recognized more and more as an important input to cognitive decline. And then other organics, things like glyphosate and toluene and benzene and formaldehyde and things like that. Third group is energetics, incredibly important. Blood flow, oxygenation, mitochondrial function, ketones, all of these are critical. And then the fourth group is trophic factors. So that's 3 things. That is your hormones, your nutrients, and your growth factors like nerve growth factor, BDNF, things like that. So those are the big ones. And the common things that we do in our everyday lives that unfortunately push this. Number 1, yes, as you indicated, you can get bitten by a tick. And we do have people where they don't realize it, as you know. for 10 years and they're having problems and they don't understand, and finally find out, oh, this is what's going on. Co-infections, incredibly common, things like Babesia and Bartonella. Second thing is people who have decreased oxygenation at night, very common. It's not always just sleep apnea, but if you're not oxygenating your brain well while you sleep, then you have an increased risk for cognitive decline. And that's a common one, and it's one that we want to address. I mentioned earlier the poor dentition, so things like P. gingivalis, which, by the way, are being found in the brains of patients with Alzheimer's. And perhaps the most common one of all is insulin resistance. So for most of us, we're eating processed food. We have insulin resistance. Over 80 million Americans have insulin resistance. So of course, we always check for that. And that's something that's relatively easy to address. And because of the processed food and because of the high carb diets and because of the lack of appropriate fasting periods and because of plant poor diets and low fiber diets and things like that, many of us have insulin resistance, and that is an important contributor to cognitive decline. So I would say those are some of the most important ones.
I just think it's really nice to have somebody like yourself who has an understanding on the molecular level. You have such a solid background in science and scientific research at the level of UCLA and UCSF, and you're really lending credibility and the understanding of the mechanisms for all of the stuff that really the hippies have been saying for years. Eat healthier, drink clean water, breathe clean air, get outside, sleep.
I think this is so important because, unfortunately, there is so much polarization in the world today. There's polarization in our political system in this country. And unfortunately, there's polarization in the medical community. And so unfortunately, as you said, the hippies have been saying to do the right things, but they've been saying it without an underpinning of science. And so I didn't really believe it because there wasn't any proof. Now, what was surprising to me is when we did all these experiments over 30 years and published these various papers and tried to get at what are the mechanisms that are actually driving, why do you get Alzheimer's disease? The surprise was it led us clearly now with some proof to, okay, what are the things that are important and unimportant? For the guy who tells you to put a crystal on your head, well, maybe that helps, maybe it doesn't, but we just don't have proof yet. But for the people who are telling you, you know what, insulin resistance is bad for you, we have a lot of proof now from lots of different laboratories that in fact, this is a risk factor for cognitive decline. And so the surprise was that doing the basic science led us away from the medicine that I was trained in, the classical medicine. It shows you why that does not work for complex chronic illness. It's great for pneumococcal pneumonia. You write a prescription, you get the penicillin or you get the amoxicillin or the cephalosporins, you get better. But those are simple illnesses. For complex chronic illnesses, which is what are killing most of us today, and these are things like cancer and cardiovascular disease and neurodegenerative disease and renal failure and things like that, you have to identify what's actually driving it. And so I was surprised that the basic research led us to more of what you refer to as hippie medicine. It really tells you that, okay, this is why you need to do those things and gives you a much better foundation to stand on. And by the way, tells you which of them is important and which of them not so important. And of course, we're still learning with each patient, and we've had thousands and thousands who've come through and much more success with reversing cognitive decline than ever before. But with each one, we learn something new. We learn, and for example, issues like which of the tick-borne illnesses are most important for cognitive decline? What's the best way to improve the cognition when you have these? How important is it when you have both tick-borne illness and you have mycotoxins? Which one do you need to treat first, or do you need to treat them simultaneously? How best do you restore function to the brain? All of these things are ongoing as we now understand better what is actually driving the process.
I think it's interesting. I was just reading about the new Alzheimer's drug called Aduhelm, And it was a review in the Harvard press. And basically they said, I don't really think you should take this. I think you should think about a Mediterranean diet and exercise and community. And even Harvard was saying the risks associated with this drug are so high and the outcomes are unclear. And this is the first new Alzheimer's drug since FDA approved since 2003. And it still does not look very promising. So even Harvard was saying, yeah, maybe go back to, maybe I shouldn't call it hippie medicine, but evolutionary health, ancestral health, the way that our bodies have evolved in a healthy system before industrialization. And so even Harvard saying, well, there's this pharmaceutical that's brand new and it's exciting, but probably not.
It's a really good point. I mean, this has been a huge issue. And as you know, multiple people actually quit the FDA expert panel over the decision to approve this drug. That's how bad it was. 0 out of the 11 of the experts voted to approve it. And yet the FDA went against their own expert panel and approved it anyway. And the idea was, just what you said, it's been a long time since we had a new drug approved. Okay, but the problem is it has to be a drug that works. And unfortunately, this has shown no efficacy. The best it did in one trial at one dose, it slowed the decline. Didn't make people better. It didn't stabilize them. It slowed the decline by 22%. And in our trial, using this multi-pronged approach, we actually saw people get better, not just slowing their decline. So that's a huge difference. And over $28 billion were spent to develop this drug, which unfortunately doesn't work. And as you said, it has significant side effects, brain swelling, and in some case, microhemorrhages in 40% of the people. So this is a truly high rate of side effects. And unfortunately, as I'm sure you know, a few weeks ago, someone actually died after taking this drug. So this is a huge, huge issue, and we simply need to do better. The idea that we have to approve something just because we don't have other things, well, in fact, we actually have other things, and they're working. So we would recommend that there are many better things to do than to take a drug that is not working.
Gosh, can you imagine if our government or pharmaceutical companies or anybody put $28 billion towards the program that you're talking about? Because let's see, the side effects of exercise and eating well and taking supplements and getting your body free of infectious pathogens. Well, the side effects would be good health.
Yeah, and it's amazing. You just read this thing from Harvard. Well, we have published studies showing improvement with the protocol we've developed. I'm sure they didn't mention that protocol, those published studies, in what they're saying. They don't quite understand yet that yes, it's not just do some exercise. It's first do the testing to determine what's causing the problem and then address those things.
And the personalized medicine aspect, you say in your book, no one is going to be having the exact same protocol, right? Because it depends on which 36 holes are the most, or maybe bigger in each individual.
Exactly. So as you can imagine, there are some people, and we actually, because of this, we see different subtypes. There are some people where the main problem is ongoing inflammation, and it can be from many different pathogens. We got to find that out, and we got to treat that one. There are others where the glycotoxicity, the insulin resistance, and the damage from non-enzymatic glycation of proteins, of course, what we measure is hemoglobin A1C, but of course, hundreds of proteins are glycated inappropriately. This means they don't function as well. This means they are more inflammatory. So there are a lot of people that have that. That's what we call type 1.5, because it's got both some inflammation and some atrophic activity. Then there's a type 2 where it's more about a reduction in support, low hormones, low nutrients, low growth factors. Very different type, but we got to address that. Then there's a type 3, which is more about toxins. As I mentioned earlier, it's organics, inorganics, and biotoxins like mycotoxins. And there's type 4, which is vascular. You're just not supplying the brain. You don't have the blood flow to do that. And then type 5 is traumatic. If you've had a history of head trauma, you're at increased risk. So as you said, these are all different, and you have to treat them differently for the best outcomes.
And so how could a doctor do these assessments? You talk about how everyone should have a cognoscopy before or after age 45.
Yeah, so when you turn, if you're 45 already, or if you're over 45, please get a cognoscopy. It's relatively straightforward. It's some blood tests that look at the very things we've been talking about. It's a simple online cognitive assessment, which takes about 20 minutes or so. And then if you're symptomatic or if you're scoring poorly, then you of course want to have an MRI with volumetrics. But if you're just there for prevention, no problem. Just get the first two. You don't need the MRI. So yes, everyone who's 45 or over, just as we know when we turn 50, we need to get a colonoscopy. If you are 45 or over, or if there's a strong family history of Alzheimer's disease, please get a cognoscopy, look at these various things, get on active prevention, because there are 4 stages of this. There's the pre-symptomatic, there's the subjective cognitive impairment, there's the mild cognitive impairment. So that you can see, that's already the 3rd of the phases here. And then there's full-on Alzheimer's disease. So we have a long run-up where we can really address this. If everybody would get on appropriate prevention or earliest reversal, we absolutely could make this a very rare disease, which is just what it should be.
And so focusing a little bit on tick-borne disease, I know my husband and I met with you a long time ago, well over a decade probably, to talk about tick-borne diseases and Alzheimer's. How did it come into your realm that this could be? I mean, well, I know that there have been studies about Lyme disease causing Alzheimer's for many years, but they're not usually recognized by people at UCLA and wherever you were at the time. So how did it come across your radar?
Yeah, that's a really good point. And of course, it's still controversial. Most of the centers don't recognize things like mycotoxins and don't recognize Lyme disease as a potential contributor to Alzheimer's disease. But as you can see, the theory and the practice come together beautifully here. The theory is things that cause you to have ongoing systemic inflammation or brain inflammation, things that activate NF-kappa B, which is an inflammatory mediator, again, can be traced right to the amyloid we associate with Alzheimer's disease. Now, the practice is we see it again and again, and people have reported it again. In fact, some people have argued that Alzheimer's is nothing but neuroborreliosis, and it's not turned out to be that simple. There are many other things, just as you mentioned a few minutes ago. But absolutely among those is tick-borne illness. And we just, when we did our trial recently, which was a proof of concept trial, as Dr. Kat Toops, who works in this area, pointed out, about half of her patients had mycotoxins and or Lyme disease. Many had both, or tick-borne organisms, others Babesia, Bartonella, things like that. And then beyond that, we also see specific cases. And so actually, I referred one patient to your husband, who has treated her very successfully. It was an amazing story, a woman who is at the highest risk, ApoE44, and in her late 40s, she began to have cognitive decline, very typical story, developed very typical mild cognitive impairment, even beyond mild cognitive impairment. So she was really struggling. And she had a number of these things. She did have a lot of insulin resistance, which she then healed. She had some ongoing inflammation, which she improved. So she did these things and improved. But after a few years, and I should say she went from 35th percentile to the 98th percentile on her cognitive testing, did absolutely beautifully. And she's, she's really a role model for so many people. And she, of course, had Alzheimer's in her family. And had the common gene ApoE44. She was a homozygote. She is a homozygote for those. So now, after a few years, she began to have some decline again. And so we asked, what are we missing? What has been missed here? And I told her, look, you need to get this set of tests. But I'm a researcher, so I could only encourage her to do this. And so I finally convinced her after several months, please go get these tests. She got them and they were strikingly positive. And so she really had a tremendous amount of ongoing inflammation from something. And the question was, what was that? And so it looked like a good likelihood was tick-borne illness. Now, she had had 10 years before that a clear tick bite. She'd been treated for Lyme, but everything was fine. But they never treated her for any of the associated, the co-infections, which, as you know, happen in more than 50%. I mean, you're an expert in this area. You know this better than I do. And so it turned out, and Dr. Schweig, your husband, found out that she had babesia, which is a very common co-infection, and treated her for that successfully. And she, again, has improved still further with treatment, with appropriate treatment for her babesiosis. So again, something that comes up in many people, and this is a relatively common contributor to cognitive decline. And yet, as you know, so many doctors are not even checking for it. And this woman had seen multiple doctors before she saw Dr. Schweig, and they had not picked up on this.
Do you get pushback when you talk to your medical colleagues outside of the tick-borne disease world, which you're not really so much a part of? Yeah. Do you get a lot of pushback and raised eyebrows when you talk about tick-borne disease being related to Alzheimer's?
Well, it's interesting. You said when I talk to my colleagues, most of my colleagues will no longer talk to me because they think that what we're doing is so far off what they're doing. And yet, if you think about it for 30 seconds, the idea of we're just going to keep going at this with one drug, one drug, one drug, one drug, it's, you know, it's the old thing they say about insanity. It hasn't worked. There have been over 400 clinical trials for Alzheimer's that have failed. So this has been, again, the area of greatest failure when it comes to therapeutics. We're saying something that actually makes a lot more scientific sense. This is a multi-pronged illness. You've got to look at the contributors. Again, it is ultimately a network insufficiency. And I believe that we're going to all do the best when we bring the targeted drugs together with the personalized protocols. That's the way to go for this. That is the way to get at this. And so, in fact, that's the way that makes the most sense. But what happens is the groups that are trying to develop the drugs are looking at the bottom line. They're like, okay, we're just going to sell this drug as a monotherapy, even though it doesn't work very well. We need to get, for best outcomes, we need to bring these together. And I look forward to the day when there's enough enlightenment in the medical community, which unfortunately just isn't the case today. But I look forward to the day when there's enough enlightenment that we can bring these together for the benefit of the patients.
Can you explain a little bit about the newest theories on amyloid plaques and there being a response to infections and other triggers?
Yeah, that's a great point. So for many years, it's been controversial. Our amyloid is the amyloid that collects in the brains of Alzheimer's. This is a fragment of a larger protein, it's a little peptide, and there are many other things in these plaques, but that's the dominant peptide species in these plaques. And you get these plaques throughout your brain, but they are typically in specific areas such as hippocampus and things like that. So you get these things and they're associated pathologically with Alzheimer's. But are they the cause or are they the effect? And it's hard for people to think and realize it's both. And you know, brains are complicated. And what's happening, again, a little bit like what happened with the pandemic, you have a situation where you have insults. You respond to those insults with something that is both protective and downsizing. Again, just like what happened with the recession that hit our country. So when you make this amyloid, it has a beautiful antimicrobial effect. It's antiviral. It's antibacterial. It's a really impressive. It's a little bit like putting bleach on your brain. So when you put bleach on something, of course, and I did that to one of my shirts years ago, was great, got out the stain. It also got out the shirt color. So this is exactly what's happening when you have the amyloid. It is protective. It is a response. Now, for years, it was thought that it was simply the driver of the disease. And therefore, the drug companies said, let's get rid of that and everything will be great. And they spent billions and billions of dollars doing just that. Unfortunately, it has turned out it's much more complicated than that. It is also a protectant. So when you're removing it, you're removing something that's protective. So what we want to do then is a very different strategy. Just as you and I talked about, we want to look at what's causing the brain to make the amyloid. It may be a tick-borne illness. It may be air pollution. It may be insulin resistance. It may be leaky gut, and so forth and so on. So you want to remove the things that are actually contributing, that are making your brain cause it. Now, it's understandable why people got it wrong, because if you look at individuals, the rare individuals who have mutations in the APP gene itself, which gives rise to the amyloid, they develop Alzheimer's. And so it makes sense to think, aha, that must be all it is. Well, yeah, but those are rare individuals. The vast majority of us develop it because we have these insults and we're therefore having to make it. In other words, amyloid itself, the amyloid peptide, is actually part of the innate immune system. So just as in COVID-19, where people die from cytokine storm, in Alzheimer's, we're dying from cytokine drizzle. It's a little bit of innate immune system activation, which isn't going away for dozens of years. And ultimately, we're downsizing, downsizing, downsizing. So if we can determine what's causing that, we come after that. Now, I should say there was a beautiful presentation by a very well-known scientist just recently at an Alzheimer's meeting, and it was wonderful to hear. He was one of the early ones to say that, yes, amyloid looks like it's a response to something. And as he showed, when you have metals in the brain that are giving you free radicals that are damaging your brain, the amyloid actually quells that. It actually mitigates the free radicals coming from those metals. So there are multiple ways in which the amyloid that we have vilified over the years is actually a protective response. We dislike it because it's a downsize. It's downsizing. It's like your CEO of your company saying you got to tighten your belt when you don't want to tighten your belt. Okay, well, let's go out and find out why the CEO is asking you to tighten your belt, and then you can do much better.
It sounds a little bit like cholesterol. I don't want to get too sidetracked, but
yeah,
cholesterol was seen as the villain.
Yes.
And they realized that it's actually your body's healthy response to damage. And so it puts down cholesterol as a Band-Aid where there's damage. And so it's not about avoiding cholesterol, it's about avoiding what's causing the damage, where the cholesterol has to come in as a Band-Aid.
Yes, that's a beautiful analogy. It very much the same thing. I think we're all beginning to understand these organismal systems, work together. The amyloid is not trying to give you Alzheimer's, it's trying to protect you against what is giving you Alzheimer's. And similarly, as you said, the cholesterol is not trying to give you heart disease, it's responding to the stuff that's trying to damage your vessels.
Can you explain a little bit about the genetic predispositions, the ApoE4 and the ApoE3?
So there are two pieces on the genetics. So there are just the rare genes that give you that rare, truly familial Alzheimer's, and those are APP, presenilin 1, presenilin 2. And that's in fewer than 5% of the cases. So for 95% of us, we get sporadic Alzheimer's disease. And that has genes that increase your risk, but they are not determinate. They're not fate. They just increase your risk. And the most common one, as you said, ApoE. And basically, you get one copy from your mother and one from your father, of course. And so, for example, I checked myself. I'm the most common one, ApoE3/3. If you have a single copy of ApoE4, which about 25% of the population has, so about 75 million Americans have a single copy, then your risk goes from the background, which is about 9% risk, to about 30% risk during your lifetime of getting Alzheimer's. And if you have two copies, and that's 7 million Americans, then it's well over 50%. Most likely you will get Alzheimer's disease during your lifetime. And so none of them should get it. We want for everyone to know their ApoE status, which, by the way, is part of that cognoscopy we talked about. So therefore, you can address this and prevent your cognitive decline. So yes, it's important to know your ApoE status. And again, it's been all backward because people didn't understand this. So in fact, it's been said, don't bother to check the status because there's nothing you can do about it. Nothing could be further from the truth. Everyone should check their status because there's a tremendous amount you can do about it. virtually nobody should get this illness if they get on appropriate prevention or early reversal. So please find out your status. There's a whole website devoted to this called apoe4.info that was actually started by the patient who saw your husband that I mentioned, who's, by the way, is doing wonderfully. So that's the most common gene. There are about 30 others that people look at as well, but that's the most common one and most important one.
And can you talk about the ApoE33? You said it's the most common?
Yeah, it's the most common, and it's about a 9% lifetime risk for Alzheimer's. Now, those of us who are ApoE33 or 2,3, which is the more rare one, the 2,3s are actually protected against Alzheimer's disease. And by the way, in macular degeneration, it's flipped. The ApoE4s are protected and the ApoE2s are at increased risk. But in Alzheimer's disease, the 2s are the prevention and the 4s are the high risk. But those of us who are 3,3 or 2,3, when we do get Alzheimer's, it tends to be more of a toxin-associated Alzheimer's and less of the glycotoxic only Alzheimer's. So we got to think about toxicity when we see people who are 2,3s or 3,3s developing Alzheimer's. Another one that the 3,3s can get is vascular component, vascular type Alzheimer's disease.
And what are the options? Did somebody have to be one of those ApoE2, 3, or 4, or could somebody not have any of them?
No, you absolutely, everyone has 2 copies, one from their mother and one from their father. So your choice is, 2,2, which is extremely uncommon, 2,3, 3,3, 3,4, or 4,4. Those are the vast majority of people have those alleles. And so, as I said, the 3,4s, it's about 75 million people, 3,4s and 2,4s. And then the 4,4s, it's about 7 million Americans. And so again, please find out, please address this. There's so much you can do. Please don't wait.
Can you share a little bit about your clinical trial that has just been accepted for publication?
Yeah, very enthusiastic about that. And so I was honored to work with Dr. Kat Toops, Dr. Anne Hathaway, and Dr. Deborah Gordon on this. And this is a trial in which, instead of predetermining a treatment, typically a drug, we looked for each person, what are all the things that are driving their cognitive decline, and then address those things. And it was really fantastic to see 76% of the people improved their MoCA scores. This is Montreal Cognitive Assessment. 84% of the people improved their CNS vital signs scores. This is an online cognitive assessment that's more sensitive than the typical testing. And interestingly, people even improved their MRIs. So they had increased gray matter volume. They had improved hippocampal volume compared to even normal aging, let alone people who had Alzheimer's or pre-Alzheimer's. So very enthusiastic about that. And we're actually now setting up a larger randomized controlled trial that will begin later this year.
Great. And you have a new book out as well.
And that's called The First Survivors of Alzheimer's. The thing that was most exciting to me over the last years, since we had treated the first patient in 2012 and reported this in 2014, first examples of cognitive decline, just these wonderful stories from people about how it affected their lives, how it affected their families, how it affected their working. One guy said, I've allowed myself to talk to my grandchildren about my future once again. I mean, that was so heartwarming. So I asked 7 people to write their own first-person stories and then put in also updates on trial and things like that, updates on the approach we take. And just the stories are wonderful to read. And also it gives people some hope and gives people some understanding that, yes, I can do this. This is something that actually can impact so many people. In fact, one of the guys was actually writing his own book when he had first got a diagnosis about descent into Alzheimer's. And he then changed and published a book called Defeating Dementia because he did so well. So it's wonderful to see these stories.
And how can viewers find out more about your protocol?
Yeah, thanks so much. We have over 2,000 people have trained in this protocol. And so you can actually look up RECODE, it's RECODE 2.0 training. And this is for neuropsychologists and health coaches and physicians and anyone interested in preventing and treating cognitive decline. You can also get information at drbredesen.com. You can also get information at apollohealthco.com. And for the cognoscopy, you can look at my cognoscopy, cognoscopy.com, and to see what the tests are. And so all of these things are readily available.
Well, thank you, Dr. Bredesen, for joining us on the Ticktective podcast and video series. We're very grateful that you're doing this important work.
Thank you so much. Thank you so much, Leah, and thank you so much for all the great work you've done to reduce the burden of tick-borne illness. This is such a huge issue. And let me just add one quick thing. I recently got a note from a group in Australia that is trying to change the national health care to recognize some of these things as issues. And the entire national healthcare system of Australia refuses to recognize that mold has anything to do with illness. So we're really, in some areas, we're really still in the dark ages. We've got to convince people that things like tick-borne illness are critical for your cognition, and things like mycotoxins, and that we can't bury our heads in the sand and assume that we're going to fix everything with a simple prescription pad.
Amen.
Thank you, Leah.
Dr. Bredesen.
Great talking to you.
Thank you for joining us for this episode of the Ticktective podcast and video series, a program of the Bay Area Lyme Foundation. You can find out more or donate at bayarealyme.org.